Thank you so much for joining us today. I'm Nicole, the Continuing Education Coordinator for the Collaborative for Accountability and Improvement, and we're thrilled that you're here to join us for today's webinar, Two Sides of the Coin, a patient-provider dyad explore diagnostic error and the benefits of CRP. I would like to start by welcoming today's speakers, Suz Schrandt, a Senior Patient Engagement Advisor at the Society to Improve Diagnosis in Medicine, and Founder, CEO, and Chief Patient Advocate at Expect. And Eric Thomas, an Associate Dean for Healthcare Quality at the McGovern Medical School at the University of Texas, and the Board President of the Collaborative for Accountability Improvement. And thank you both so much for being here today. We're thrilled to have you share your expertise and your knowledge with our learning community. And with that, I will pass it off to you to walk us through today's presentation.
Great, thanks so much, Nicole, and thank you to the collaborative. I'm very happy to be with all of you today. I'll start just by walking quickly through our learning objectives, just to understand both the system factors and the individual factors that can lead to diagnostic error, and then to think through the benefits of a CRP response following a diagnostic error. We're also going to, through some lived experience, talk about the consequences of a poor response to diagnostic error, and really understand the importance of engaging with, listening to, and learning from patients and families following diagnostic errors. So as Nicole said, my name is Suz Schrandt, and I'm going to walk through my story of diagnostic error. It's sort of a diagnostic error wrapped up in a couple other potential medical errors, but I'm going to kick us off this way. So you can go to the next slide, please, Nicole. So my background, just quickly, is I'm a longtime patient advocate. In my professional capacity, I've worked in health policy and patient advocacy and patient engagement for a very long time. And personally, that it all started because I have polyarticular JIA. I was diagnosed right before my 14th birthday, and it extended into adulthood and now acts and behaves just like adult onset rheumatoid arthritis. So I've sort of been around the block, so to speak, when it comes to medicine and navigating my own healthcare. My surgical history, and this will become important in a minute, but my surgical history I'm sharing with you because I've had multiple joint replacements, and in each case, I had unexplained excessive post-surgical bleeding. With my knee replacements, I required 4 blood transfusions. I required 2 blood transfusions after my right wrist arthrodesis. There was not any surgical complication per se. The surgeries themselves went fine, but there was just this long excessive bleeding after all of these surgical events. So if you go to the next slide. When it came time to have my left wrist replaced in 2015, I had moved to a new city, so I was starting over with a new surgeon. And I went and explained, we don't know why. I've had a bit of a workup and we haven't found any, there's no von Willebrands, there doesn't seem to be a clotting disorder, but I just have this strange history of excessive post-surgical bleeding. And I told him, it doesn't frighten me. I need this wrist replacement, but I just ask, let's do it inpatient. Can we leave the drain in so that any excessive bleeding can come out of the surgical site, and so that we can have the right blood units on hand. And he just didn't feel like it was necessary. He said, I think techniques have improved. I think I can manage any of this with cauterization. He just wasn't moved, didn't want to do it inpatient. And I agreed to move forward. I should put a big asterisk there that I even on the day of the surgery, driving to the hospital, I was incredibly apprehensive, and I just felt like this was probably the wrong choice. But as silly as it sounds, I had already taken off all of my days from work, and I was just going to do it. So I moved forward. So we can go to the next slide. And next slide. So I report again with immense apprehension. There was a nerve block from the neck down for the surgery. It did go as planned mostly. It took about 2 hours, about twice as long as it was expected to take. There was a lot more damage than he had expected. But the implant went in. It didn't seem like there were any issues. And so my discharge instructions were just to keep it bandaged in a soft cast, keep it elevated, and some bleeding and swelling and discoloration would be expected. So we can go to the next slide. Even within the first 12 hours, I would say, as soon as the nerve block started wearing off, something just felt not right. And I'm pretty accustomed to pain, even post-surgical pain. I've had a lot of it in my life. I was taking the prescribed OxyContin, I was elevating, I was icing, but something just wasn't quite right. So I tried to get some sleep. So we can go to the next slide. But by about 24 hours post-op, I'm pretty miserable. It's a gnawing pain. I couldn't quite describe it. What had been a soft cast had now become completely hardened from all of the bleeding. I was starting to kind of lose sensation, getting kind of pins and needles in my fingers. So we texted, my surgeon gave us his cell phone number. I was texting photos and said, something feels funny. So he said, why don't you come in? We'll check it out. So I came in and he had to really forcefully cut through the cast to try to get, to get it off. It was so hardened from the bleeding. But he took a look and said, I think it's fine. I think it's normal post-surgical swelling and pain and discoloration. So he put a new soft cast on and sent me back home. So we can go to the next slide. Now about 12 hours later, we're still going south. I'm having this gnawing, horrible pain in my hand and in sort of the bases of my fingers, but farther out, I have little to no feeling in any of my fingertips. My fingers are starting to get cold and turn, the picture doesn't quite do it justice, but really blue, kind of this just upsettingly blue hue. I'm sending photos and he's still pretty convinced it's normal post-surgical swelling. I just need to stay up on the pain meds and keep elevating and icing. And you can see on all of my proximal IPs, on all of the knuckles there, you're starting to see these little tiny white kind of circular areas. If we go to the next slide, I was actually starting to develop blistering. So by 48 hours, I'm 2 days out, I haven't slept. And actually my husband became the real advocate here because I was a little loopy from the OxyContin. And he came to check on me and felt my hand, and I couldn't feel him touching my fingers. They were ice cold. I couldn't take it anymore, and I took off the cast, and it revealed all of these blisters, pretty large blisters. So this was really my first objective clinical finding. My reports of pain and numbness and the blueness was hard to see across the phone. So when I sent this photo to the surgeon, he said, go to the emergency room immediately, we will admit you. So we can go to the next slide. So this is shot from inside the emergency room. It's a bad sign when 4 or 5 people swarm in because it's going to be a cool learning opportunity. So there was a large team of folks that came in to check things out. So at this point, my hand was just enormous. If you go to the next slide, I actually took some pictures for just comparison's sake. I'm not a particularly petite person, but my hands are kind of scrawny, bony. I have a lot of wasting in my palmar fascia, and even my thenar eminence and hypothenar eminence are both kind of wasted from years of arthritis. So you can see how marked this swelling was. If you go to the next slide, and then one more. I mean, this was profound. It looked like a monster. So if we go to the next slide, I can kind of walk you through the assessment here. So in fact, what I had said would happen had happened. I had had excessive bleeding. There was nowhere for it to go. It had caused sort of a compartment syndrome-like event. So I was actually NPO for the first 4 days in the hospital because they kept trying to decide, do we need to do a fasciotomy? If we do another surgical intervention, is it just going to make it worse? So all the while, we just did sort of a strict elevation protocol. They hoisted my hand up to an IV pole and just hung it there to keep it elevated, did a lot of steroids, IV steroids. And it did start to subside. It just took a lot of time. So I was able to go home on day 5. And by then I had begun to regain just a little bit of sensation in my fingertips. And we just continued to do that strict elevation and steroid protocol at home for about 3 more weeks. But really it took months before I got all of my sensation back. I still have a little bit of permanent nerve damage. But I'm going to share more about my outcomes a little bit down the road. So I think at this point, I'm going to turn it over to you, Dr. Thomas.
Hi, good afternoon. I'm Eric Thomas, and I have been doing research on patient safety for about 25 years, including some research on diagnosis and a variety of other topics in the field. I'm also a general internist. I do adult primary care, just outpatient primary care here at the McGovern Medical School at University of Texas Health Science Center, Houston. And so I'm going to talk about some of the basics of diagnosis and diagnostic error, and I'll be engaging Suz in this as well as we go through some of these things. And I did want to start with this report from the National Academy of Medicine. For those of you that are not aware of it, it's a really important document that provides a wonderful foundation on this topic of improving diagnosis. Next slide. And one of the things that they did in that report is to come up with a somewhat new definition of diagnostic error. And so it has two parts. So a diagnostic error is the failure to establish an accurate and timely explanation of the patient's health problems, or to communicate that explanation to the patient. So it's both the accurate and timely diagnosis, and then there's the requirement to communicate that explanation to the patient. So a physician could make the right diagnosis, but if it's not communicated to the patient or the family, then obviously it's not being useful, and it still would be a diagnostic error. And so so just was going to go ahead and stop here and ask Suz, how she sees her experience as fitting or not fitting within this definition of a diagnostic error.
Yeah, I think that's part of what's so complicated about diagnostic errors. Sometimes it's not a clean fit. I think there were several things going on in my story, but certainly the post-surgical experience. So as these symptoms are mounting and I'm not being listened to, it is very clear to me that there was just an overall issue with not understanding or believing the information that was shared. So it does fit in that there was not an accurate or timely explanation. Nothing was really communicated to me because he didn't believe anything was wrong. So it's a difficult, it's not a perfect fit into this definition, but I certainly see elements of what happened to me reflected in the diagnosis.
Mm-hmm. Yeah, I mean, I think, we could say that there was a delay in diagnosis of the postoperative bleeding. The surgeon had a chance perhaps to diagnose that when you went back to the office and had the cast changed. And if not then, at least 36 hours when you sent him more information and explained more about what was going on, that it probably could have been diagnosed at that point in time. So so this does, definitely seem like a diagnostic error in that sense. And there's also the question about, why Suz had the bleeding problem, and that was never diagnosed before. She didn't get into it, but there had been some attempts to evaluate that. And it may be, in this case, that there really is no specific diagnosis that explains why she's had bleeding complications after surgery. Next slide. So just a little bit about what we know about the toll of diagnostic error. If you look on the left, there's perhaps 40 to 80,000 deaths per year in the United States from diagnostic error. And research that I did with Hardeep Singh in the outpatient setting suggests about 1 in 20 primary care visits involves a preventable diagnostic error. And on the right of this slide, there's estimates that there in each hospital, there are probably 10 deaths on average every year related to diagnostic error. Lots of harm, lots of diagnostic errors that don't cause physical harm as well. Next slide. And they happen in the kind of the usual places. Most diagnostic errors are happening in the outpatient setting, just because that's where most patient encounters occur. The rate of diagnostic error is probably higher in other settings, but still the absolute number are most common in ambulatory care. They happen in the inpatient settings and the emergency department as well. Next. And one of the take-home messages of the report from the National Academy is that it is likely that most of us will experience at least one diagnostic error in our lifetime. And, you know, if we were to pause here and get input from the 70 or so people on the call here on the webinar, many of you would have experienced a diagnostic error yourself or known someone that has. They are not at all rare. Next. So here's a nice overview of the diagnostic process, and I'll kind of just quickly walk through this first, and then we can talk about how the process can fail. But if you look in the middle at the figure here on the far left, the beginning, of course, is a patient who's experiencing a health problem and then engages with the healthcare system. And then there's this circle of the diagnostic process where information is gathered from the patient, from the record, that's integrated and interpreted, and a working diagnosis is made, and perhaps that goes around a few more times as more information is gathered, and eventually there's a diagnosis made. It's communicated to the patient as we go over to the right. There's some treatment, and then hopefully some beneficial outcomes for the patient. And then if you look up at the top, there's some places where there are failures in the diagnostic process. And so, Suz, I was going to ask you, what was your impression of where there were some failures in the diagnostic process in your case? What did you notice?
So, you know, obviously I took the first two steps. I knew I had a problem and I went to get help. And I felt like I did a good job conveying all of the information that I had. So I don't think it was the information gathering issue. But one challenge I did have is that I didn't have, you know, medical documentation. It's very curious, but when we went back to try to find some just data, some explanation from the prior bleeding events, that it was not readily available in my medical record. Now, my knee replacements were a long time ago. That institution doesn't even exist. The hospital has been torn down. I don't believe that surgeon is alive anymore. He was in his 8th decade, I think, when around, you know, recently. So I don't think he's definitely not still practicing. So it wasn't possible to kind of hand over another clinician's assessment or even just a characterization of what happened. It was just my language. I think that was probably a deficit. It's not an excuse. I laid out a pretty clear picture of what was going to happen, but I've always wondered if there was other information I could have provided that came from a clinician, if that would have been helpful. I've wondered if there was maybe some cognitive bias because I looked relatively healthy, even though I have this underlying condition. I don't look like there's a lot going on. So maybe there was something about just the way I was presenting. And then probably because I work in health policy and have been in this space for a long time, I'm very mindful of whether there were sort of system pressures on him. Something like doing the patient inpatient versus outpatient, or doing the surgery inpatient versus outpatient. Was his decision more rooted in he's going to get in trouble, or there's going to be a review of why was this inpatient when it was only a quote unquote simple surgery? So I think there's a lot of pieces in the information integration and interpretation part that really resonate to me.
Mm-hmm. Yeah, that makes a lot of sense. Of course, we don't know for sure what was going on in the physician's mind, but there does appear, you know, before the surgery that there was some failure of integrating and interpreting the information that Suz was providing him. He didn't acknowledge the potential risk, or didn't act to acknowledge the bleeding risk. And then as Suz says, there are these, you know, systems factors that can certainly influence decisions in either a conscious or unconscious manner. So next slide. And this is just also a reminder, it's not necessarily Suz's diagnostic team in her particular case, but just in general, the diagnostic team can become quite complicated. So in my clinical setting, a patient comes to see me as a primary care physician, and immediately, that patient and family is engaging not only with me, but with nurses and medical assistants and trainees. And then, of course, as we work to make a diagnosis, we're engaging sometimes radiologists, pathologists, specialists, and lots of other healthcare professionals as well who are, doing physical therapy or home visits, and lots of other things. So just a reminder that our teams are extremely complex, and they're necessary and they're very helpful in making diagnosis, but because of the complexity, they are prone to failure. Next slide. And this is just kind of focusing on this triangle. There's a lot of these system factors that influence our care at the so-called kind of blunt end of the system. And then at the sharp end is the me here is me like a clinician seeing a patient. At that sharp end where the clinician is taking care of the patient, there are also, in addition to the system things bearing on them, there are these cognitive issues about making a diagnosis, about how our clinicians think and make decisions. Next slide. Just a reminder again about how complex healthcare is, whether it's the amount of information that's crammed into EHRs, look-alike, sound-alike drugs, the technology and the teams, all are life-saving things, but also things that our abilities to communicate and work with teams and create safe systems hasn't really kept up with how complicated things are and make them prone to failure. Next slide. And then when you look at diagnostic errors, this is just one study, but you pretty much see the same things about the kinds of system errors that lead to problems with diagnosis. Communication is certainly very high on the list. In the outpatient setting, one of the most common problems is communication of abnormal test results. Results get lost, sent to the wrong person, or they're just not acknowledged and acted upon appropriately. There's issues with coordination of care. Suz mentioned this in her case, that there were no medical records available from her prior bleeding events that might have been of assistance in helping her surgeon understand, the seriousness of what had happened before. Sometimes there's problems with the availability of expertise. We've got cultural problems where we're not reporting and learning from errors. Adding trainees into the mix can cause challenges. We have got workload, stress, distractions, and other issues as well. The bottom here is that concept of normalization of deviance. We have these breakdowns in our systems, and we often just think that that's just the way it is, that that's just normal, and we live with them. And sometimes we get lucky and they don't harm patients, but obviously quite often they do. Next slide. And we can go to the next slide, please. So also talk a little bit about cognition and clinical reasoning. This slide is illustrating what's called System 1 or intuitive reasoning, and then System 2 analytical reasoning, kind of two systems for thinking that physicians tend to use. So Systems 1 is also called kind of heuristic, or a heuristic is like a rule of thumb. It involves pattern recognition and very kind of quick decisions. So, for me as an outpatient primary care physician, if a 60-year-old man who's a smoker and has high blood pressure and diabetes comes to my office saying he's having chest pain, I immediately think he's having angina and maybe a heart attack, right? It takes a couple seconds to come to a diagnosis. And so that's a kind of reasoning that is beneficial in many ways because it's quick, it doesn't require a lot of effort. But the problem is that it's not very analytical, and sometimes it's prone to error. If I was doing a System 2 kind of analytical thinking on that case, I may not jump to the diagnosis so quickly, but I might ask him more questions about about how does the pain feel and are there other symptoms associated with it. I would do an exam, get an EKG and get some blood tests and kind of more stepwise go through a process of analyzing data to come up with a diagnosis. I'll just highlight this one issue here of emotional component is what that's referring to is that in the system one intuitive, kind of rule of thumb thinking, emotions can tend to influence it more than the analytical thinking. So if I'm anxious or if I'm stressed, I may make more mistakes with this quick intuitive thinking than I would if I slowed down. And of course, that's one of the recommendations that if you're under stress or anxious or in a complex environment, you do want to slow down and pause and think through your decisions and make sure that they're correct. So that's just a little bit about clinical reasoning. Can I see the next slide, Nicole? Just want to check. Yeah, so again, these cognitive shortcuts can be helpful if they help us to be efficient. They're usually correct, especially for an experienced clinician, but there are some thinking traps that we can get into. And the next slide talks about some of the common biases. If you do some reading or go online, you'll see dozens of different cognitive biases. This is just a few common ones. So there's one called the availability heuristic, where the diagnosis of the current patient is biased by experience with past cases. So especially recent past cases, clinicians remember those, and they tend to always apply them to the current patient, even though that may not be the right thing to do. There's also an anchoring heuristic where you rely on an initial diagnostic impression despite subsequent information to the contrary. There are framing effects where kind of some subtle cues and collateral information about a patient might influence your decision-making process. And then there's a bias called blind obedience where you put undue reliance on an expert. So I was going to ask Suz to reflect on these biases. And again, of course, we can't put ourselves inside the brain of the surgeon, but if Suz, I don't know if there's some reasons to think that some of these biases may have been at play in your case.
Yeah, I think kind of with these biases, and then it makes me also think of your system 1 and 2, the schematic you showed a minute ago. I mean, I think the availability heuristic jumps out at me because it seemed like this is a surgery he's done many times. It would probably typically be in healthy people who've had an injury or an accident. And so he just sort of applied what he always applies, and he went forward the way he always goes forward. Mm-hmm. And then I think when you and I talked recently, I think the anchoring heuristic also makes sense because even though I had shared all this information going in, I start developing these symptoms immediately after the surgery, and it's still not, he's anchoring back to his original sort of diagnosis of there's nothing to worry about here. Even though I had sort of offered up and it happened almost in the exact way I said that it would. Mm-hmm. So I think both of those things jump out to me.
Yeah, and again, it's, and none of this really explains one of the great, I think, conundrums of a lot of diagnostic errors is oftentimes we're looking back at it and we're like, why didn't the clinician listen to the patient? So many patients tell us over and over, I told them that this was going to happen, or I told them that this might happen, or I told them this information. And, there are these biases, there are these systems issues that can partly explain some of that, but in the end, sometimes it seems quite unsatisfying that we don't really understand, where you have someone like Suz who provided as much information as was needed, really, and still the right course of action wasn't taken.
Yeah, and I sort of have my own N of 1 experiment I can run, because since my wrist surgery, I had a hysterectomy just a year and a half ago, which are bloody surgeries. I was very nervous about it, but I had many conversations with that surgeon, and she just kind of took a whole different path. In your system 1, system 2, she's really a system 2. We still don't have a diagnosis for my bleeding disorder, but she was very regimented. I had to go get a new full workup from a hematologist. We did things like eliminated all of my RA therapies for, I want to say, multiple weeks before the surgery. There's I believe, a blood thinning shot that is often administered before, or at least before the hysterectomy she does. And she skipped that. I mean, she was, and it went off beautifully. So there was a way, it sort of solidified for me that there was a way around this. Even though it wasn't a bright, clear path with it, she had to sort of make it up as she went, but she did, and it worked. So it gives me my own little experiment to see how different a care pathway can be.
Yeah, yeah. Thanks for sharing that. That's very, very, illustrative. Okay, Nicole, let's we can catch up to here. Okay. So we'll hear more about Suz's case, but also, and she'll tell us more about her experience after this event. And I think here, for those of you that have been a part of these webinars before or follow the communication and resolution program or the candor type approach to following up with patients after harmful events, you'll be familiar with some of these, but the question is, what do patients want after an event like this? And they want to know the truth. They want to know what happened. They want to know the facts. Why did this happen? What's known, what's unknown, what's going to happen next? As a reminder that this kind of information is often conveyed over time with multiple conversations. It's not just like a one-time thing. It's usually advised to share with the patient and the family as soon as possible what's known, and to maintain communication from the very beginning. Patients need what here is referred to as emotional first aid. They certainly need empathy and compassion, recognition and validation of their emotions. And many patients and families are really afraid of being abandoned after a harmful event, and there's a fear of that needs to be addressed as well. Accountability needs to occur. The health system, individuals need to accept responsibility for what happened quite often, including apologies when appropriate. Many patients really do want to know what's going to be done to prevent this from happening again. And so what have the individuals in the organization learned, and how they're going to prevent it from happening to somebody else? And remediation is, can be a variety of things, ranging from financial compensation for time lost from work or for medical bills, to other, things as well that can help to remediate the harm that has happened. Next slide. So Sue's going to talk a little bit about what her follow-up experience was like.
Yeah, so if you go to the next slide, thanks, Nicole. So the sort of medical outcomes, I had a really significant amount of nerve damage and sort of nerve disruption, and had to do a great deal of rehab on the nerve issues before we could even get to the wrist arthroplasty rehab. So it's impossible to know if I would have had better replacement outcomes had I not had these nerve issues. I still have lingering nerve issues in my fingertips that are new. I had sort of been lucky that with all these years of RA, I had not had carpal tunnel. I hadn't had any nerve impingement in that hand, and now from the surgery, I have some lingering issues in my fingertips. And it did exacerbate the RA in my left shoulder, because joints with that kind of inflammation do not like being held in static positions that are abnormal. So that was a sort of an additional layer. If we go to the next slide, these are more sort of the big picture outcomes. So the surgeon did apologize, and to his credit, in his apology, he sort of validated. I mean, he said, "You told me this was going to happen and I didn't listen to you, and I'm sorry." So that did feel good. I was glad that happened. Because I'm a patient advocate, what I want is change. I want to make sure we understand what went wrong and can address it so that that doesn't happen to future patients. And so that certainly hasn't happened. There's been no other reporting or communication with the hospital. In fact, I remember filling out my HCAP survey and being kind of disgusted because I could say the room was warm and the food was good, but I couldn't say anywhere, oh, by the way, there was a tremendous error and I have damage from it. That wasn't a question that was asked. One of the real head scratchers is that we paid for all of this. We paid for the extra hospital stay. We paid for extra rehabilitation. I missed additional work. When I say we, I mean, we and our health insurance. So the whole system paid more for this poor care. And I have reached out to the surgeon because one of the things I do is clinical education with patient and family partners, but it hasn't yet materialized. Initially, there was some willingness, but not yet. So that's really what I would like to see, is for he and I to partner on something that feels more like a solution. And if we go to the next slide, these are just kind of a couple of the thoughts as we go into a more detailed discussion on CRP. Um, I work with so many patients and families who've had really profound diagnostic errors. They've lost loved ones. They themselves have had, really significant harm. And so I've always felt a little funny about my story because, as it turned out, it wasn't so bad. But I think the thing that really gets me is my initial instruction was to not be seen again for 2 weeks. And I really can't imagine what would have happened. I am highly educated. I have resource. I have no other kind of constraints that others might face. So what would have happened to a differently situated patient? That's what really just kind of makes me sick to my stomach to think about. What would have helped me kind of listen to my gut? I've been a patient advocate for a long time, so it was pretty embarrassing for me that this happened. And I don't have an answer for why I didn't just say, no, I'm not going to do it this way. I'll find a different surgeon. What could have facilitated my surgeon to just hear me and believe what I was saying? If I had had my medical records, would that have mattered? If there was very clear information in there that I could actually distill and share, would that have changed my trajectory? Then sort of post-surgically, are there terms I should have used? Is there something I should have said that would have made him think, oh, I think we have a bleeding issue? I mean, is there some trigger or language that I just missed? And then, of course, along those lines, it's always been a little troubling to me that the blisters, because it's a clear, it's something you can see, were the first time he actually reacted. The blue fingers and all of my description of pain and numbness was not enough to move him. So I think there's just a lot of work to be done on all of these bullets. And so that's why I'm excited to move in and talk about CRP, and had that happened, if it might have set my mind at ease on some of these points.
Mm-hmm. So, actually, let's go back to that slide. I wanted to make a point that has become more apparent with from a research perspective, at least, with a fantastic team of investigators. We looked at surveys of thousands of patients that have been harmed by errors, and one of the common themes, years after an event, is this persistence of some regret and a lot of these questions about what if. And I don't know if this is the right word, Suz, for you, but a lot of people feel guilt as well, which is, just so, challenge is difficult in the sense that you're really kind of a victim, and yet you still feel guilt, and family members as well feel like, what else could they have done? So I just wanted to highlight that, to make sure that everyone's aware that those are very persistent, important emotions that people have. And for those of us that are healthcare providers, when we're seeing patients and families years after events, we need to be aware of those feelings. Also, fear of future healthcare, are really important. I don't know, Suz, I hope I didn't put too many words into your mouth, or if that sounds accurate.
I think that's exactly it. I mean, I have literally helped other people navigate surgery and helped them navigate healthcare. And here I got myself into such a pickle. I mean, that's kind of the way that I felt. I've I've forgiven myself a little bit more as time goes on. The blame I place on the surgeon gets a little bit higher, and my blame gets a little bit lower. But that's just because I'm working in this field and learning from all of you. It worries me that it prevents people from reporting, that they don't want to share if they feel like they have some part of the error.
Yeah, yeah. I mean, it's hard for me to imagine what else that Suze, you could have done differently. Um, but always good to ask the questions. Maybe we can learn and, and help others as well. So let's go on to the next slide. So these are just some of the generic benefits of a communication and resolution program, and we can talk about them a little bit in relationship to Sue's event. So, Suze, we don't know if this surgeon or anybody reported the event into a incident reporting system at the hospital, I guess, but you don't have any evidence that that happened, any evidence that there was any kind of an analysis and of the event and what's going to improve. So, in a well-functioning CRP, that would happen. I mean, this event would not just be kept between the surgeon and the patient and the family. A team of quality improvement, safety experts would be involved in investigating and figuring out how to prevent it from happening again. In a CRP, there is good communication with patients and families, and Suze did have some of that, and it wasn't as transparent as it should have been in terms of explaining more about why things went wrong, and the communication has stopped over time despite Suze wanting to have some more. We talked a bit about event analysis and quality improvement already that are not happening in her case but would be happening in a well-functioning CRP. Also, financial resolution would be on the table from the very beginning in an organization that was following the principles of CRP. And of course, as we've heard, that didn't happen in Suze's case. We don't know if this surgeon had any support from colleagues or peers, but care for the caregivers is definitely important. And ideally, over time, there would also be, not just telling the patient what happened, but engaging them in the efforts to make things better if that's what they want, to make sure that their perspectives are included as the organization learns and improves. So, in some ways, these are benefits of a CRP that apply to any case. And, when it comes to diagnostic error, it's particularly important because so many diagnostic errors are not reported. They're not analyzed quite often because they happen over a period of time. They might happen in both. The different sites of care are involved in the same diagnostic error. Both in Suze's case, the surgeon's office plus the ambulatory care, the surgery center, and so it's the diagnostic errors tend to be especially challenging, but also we think that CRPs can be especially beneficial in helping us to learn from them and reduce them over time. I was going to ask Suze again if she had any other comments about this relationship between a CRP and a diagnostic error.
Yeah, I mean, I think having this kind of systemic response just would have given me a launch pad. I mean, we never wanted to sue. My husband and I are both attorneys, and it didn't even occur to us to sue because we didn't want that kind of response. We wanted system change, but I wouldn't know where to go. As you said, the initial sort of error happened really in an ambulatory care setting at his office. When I was then admitted to the same hospital where I had the surgery, that felt almost incongruent. It was the surgeon who had the error. So would I talk to the hospital? Would I talk to the orthopedic surgery office? It was so even as someone who navigates healthcare for a living, I didn't even know where to go. So I just think having something that's a nice systematic approach takes away a lot of the burden, a lot of the onus off of a patient who does, I want desperately to figure out a way to turn this into a great learning opportunity. And I've tried to do that on my own with the surgeon. It hasn't worked yet. I'll maybe, give them some time and try again. But that's why I think this is so important. I think there are probably a lot of patients and families who would like to turn their error or harm into something positive. And to me, that's one of the great potentials in a CRP.
All right, next slide. And as a reminder, if some of you aren't aware, there are organizations who have implemented CRP best practices for many years and had, a variety of different, successes. There's a lot of different ways to measure success of a CRP. These are some of the more traditional ways in terms of reducing malpractice claims and saving money. Looking at this again, it's been a while since I looked at this data. It's interesting how limited these outcome measures are in terms of success of the CRP. As we've been talking today, we really are wanting to look at so much more. We're wanting to look at whether patients are served well, if they're feeling better emotionally and physically, and whether or not we're really improving safety over time through CRPs. But from a kind of a short-term financial risk management perspective, CRPs are definitely the way to go. And even more importantly, they contain the ethical and the moral and the professional. They provide support for us to do the right thing for our patients. So we believe they're very helpful in these ways and many more. Next slide. So, Nicole, I guess I'll maybe let you and Karen see if you want to moderate any questions.
Yeah, we'd love to open it up for questions. You're welcome to type your question to the chat box, or you can also unmute yourself and ask the question directly. We did have our first question comment from Gordy. How to ensure that extending focus to the broader system issues is not perceived by the patient as trying to get the provider off the hook and rationalizing the error. So Eric or Suz, I don't know if you want to respond to that.
Yeah, that's a great question. I mean, I think Suz, I'd like to hear your response at first, because do you, as we sit here and talk about the systems issues that might have influenced the clinician's decision, do you feel like doing that is kind of alleviating him of his personal responsibility and failures? Or how do you think about those two things? It's kind of this tension between system responsibility and individual responsibility.
Yeah, I think it's a really tough area, and we worked on a discussion about a year ago with a group of patients with these same kind of questions, and I think a lot of it would have to be in the messaging around that. Like if you are communicating that the system issue was the totality of the issue, that feels very different than saying we have some things in place that contribute. And in this case, doing an inpatient surgery is harder to get approved, or whatever the right language would be. It's different to say that's a contributing factor and completely absolve the surgeon. I don't think it would be offensive, or I would feel like the hospital was pushing it under the rug if they just included it in sort of if it ended up in the root cause analysis, that was part of what happened. I think the same thing has come up with patients affected by a diagnostic error, in terms of is CRP just a tool to get out of litigation? And so I think being upfront about that, like really calling it out at the beginning and being transparent that that's not what this is intended for, I think is a similar issue. Just trying to be open and transparent that this is about getting to the root cause and really figuring out how to learn from and change things that need to be changed.
We have another question in the chat box. Isaac raises the issue, what are some of the policy challenges that are needed for making CRP the default option for healthcare organizations, as opposed to a program that organizations optionally opt into?
Some of the policy changes that might help promote the uptake of CRPs. Wow. I'll have to, say my initial response is I don't know. The Collaborative for Accountability and Improvement does have a policy, committee with things that we're thinking about and working on. Suz, I don't know if you've thought or been exposed to some of the ideas that are out there for, creating, kind of system, policies and regulations and things that might help promote CRPs.
This is a very sort of business response for someone who's a patient advocate, but it comes up in so much of what I do. I think if you can tie payment and reimbursement to quality, and sort of show how reduction in diagnostic error and harm is cost saving, and in addition to improving quality, I think payment is always a key lever. So if there's some way to build in robust CRP, kind of show how that changes the entire system dynamic, there's probably a cost lever that has to be figured out. And I think just really vocal patient and family advocates is always a good force to have on Capitol Hill and elsewhere, wherever these decisions are made.
We have another question from Brian. Any thoughts about how to handle situations where a clinician identifies that another clinician has made a diagnostic error, and then whether and how to address that with the patient?
Mm-hmm. Also, just to highlight, one of our staff members of the collaborative, Paulina, posted a link to CRP policy tools. So there's the answer. Thanks, Paulina, for adding that information to the chat. And Brian asks an amazing, a really, really important question about when one clinician identifies, that another has made a diagnostic error. And how to address that with the patient. It's really dependent on the specifics of the event. I think a kind of high level approach that has been advised and that I've taken and I've seen other people take is it might be a situation where I'm seeing a patient and I, for a variety of reasons, begin to wonder if there was a diagnostic error made. Maybe the patient's not aware of it. The usual process would be for me as a physician to reach out to the other physician and go over the case and get their perspective on what happened, to gather more information. When I've done that in the past, I've kind of been fortunate in that I found that there weren't diagnostic errors that happened, and we didn't need to, get into that. Sometimes there's pretty simple explanations, and there's just been a breakdown in communication. But physician to physician, communication at the beginning is necessary to figure out what's going on, and then when the initial treating physician that might have made the error did make the error, when he or she is told about it, it's incumbent upon all of us to encourage them to tell the patient about it, be transparent and honest about what happened. So that's easier said than done, but I think that's the general approach. Suz, have you had patients or talk about maybe the scenario happening where the second physician might have discovered an error by another physician?
What I deal with most often is questions from patients about what they should do when they have discovered through their current clinician that a former clinician made the error. So there's a lot of their patients are in that same space wondering, well, should I go back to that first clinician and pursue this, or do I just let it go? Certainly if it's a profound harm, that there might be more of a motivation to either, whether that's legal action or at least going back to the health system or the hospital to try to talk about or uncover what happened. But and I'm sure there's others on the call who maybe have specific frameworks or ways to deal with this, what comes up most often in my interaction with other patients is the very same question. Is sort of what do you do when this happens? So it'd be a great thing to figure out and maybe offer a suite of approaches if that already exists.
Yeah, so Tom Gallagher and colleagues have written a paper in the New England Journal, thanks again to Paulina, that highlights kind of some of the steps. Patients and families come first, explore and don't ignore, which is kind of what I was suggesting, is we need to explore these things and see what happens. Colleague to colleague discussions can be a starting point, but sometimes this is also something that would happen at an institutional level, again, depending on the case. So again, in the chat, there's a nice link to a short little case discussion about this particular topic.
And Joe Shapiro makes the very good point that a just culture is really about both personal accountability and systems accountability. So kind of underscoring the need for that culture shift at the institutional level as well as individual.
And there's nice kind of approach by James Reason to identifying when is it a systems issue versus an individual issue, and you begin to think more about this being an individual issue if it's obviously if it's intentional harm, if the person is debilitated by some physical issues that's preventing them from doing their work. If they're repeatedly violating a known and effective safety procedure, I mean, an extreme example would be, someone that's refusing to do hand hygiene. Well, there are systems issues that go into how easy it is to to maintain hand hygiene. But if someone is just disregarding, standard operating procedures that are known to help promote safety and that are widely known and that are workable, then you start to think it's perhaps an individual issue. Although there are certainly human factors experts and system science people that would say, you can always make a system, better, and that we might rarely blame somebody for not, following a policy or procedure. But that is sometimes, a point certainly that we get to. So those are some of the factors that can be taken into account.
Linda raises an interesting point. She notes that in her medical training, it was normal to have the monthly morbidity and mortality conferences, and it really provided an open and safe forum. And in her experience, patients and family members were invited. And since entering private practice with kind of the more corporate medicine, she's not seeing that. And she says, wouldn't it be nice to have a CRP system and as kind of a learning ground for physicians in that kind of context?
Mm-hmm. That is a really important point, and it's somewhat of a I'd say maybe a limitation of where CRPs are at right now, which is they're at mostly academic medical centers or large health systems. And this approach has, not made its way out into, smaller community hospitals or, private practices and private physicians. So that's a challenge that we all have to take on.
We're coming up to the top of the hour, and there's still more questions in the chat box, which I think reflects what a wonderful session this has been. And so I think that this is a great conversation to be continued.
Mm-hmm. Yeah, thanks. I've enjoyed it.
Thank you so much. This was really informative to be able to walk through and learn from all of you. So thank you.
Thank you so much, Eric and Suz, for speaking with us today, and thank you all for joining. You will be added to our communication list so you can be the first to know about our upcoming webinar. So thank you again, everyone, and have a wonderful day.